Hello and welcome to another Piper Pod. Today we're going to continue along with pharmacology and we're going to look at the use of antibiotics. Now for those that are avid listeners to In the Pipeline, you'd know that I've done an antibiotic talk before. That one there was a live presentation I gave to a bunch of international medics, and it was a lot on the pharmacodynamics side of the house. Today we're going to look at a more generic overview of antibiotics and antibiotics use and focus more on the nursing aspect of using antibiotics as opposed to the pharmacodynamics. So starting off, let's just have a look at our general classification of antibiotics. They can be broken up into two basic modes of overall actions, and that's whether they're bacteriostatic or bactericidal. Now I know people have focused on this in the past, and you realize that bacteriostatic antibiotics don't physically kill bacteria. They're used to suppress or inhibit some form of cellular function or growth of that bacteria, allowing the body to use its normal immune system to break it down. Bactericidal, on the other hand, actually goes along and kills the bacteria itself. Other ways of classifying it is whether or not it is a broad spectrum antibiotic, which means it's effective against a lot of different pathogens, as opposed to narrow spectrum, which works on a single spectrum or a limited range of bacterial agents. Now, just for interest's sakes, there's obviously trillions of species of bacteria out there, but there's only around 100 different bacteria species that affect humans in some form of pathogenic way. So the reason we need a lot of antibiotics out there has a lot to do with bacterial resistance over the time. So not all bacterial cells are created equal. A lot of them have different structures that we'll look at in a little bit, and realistically the increase of antibiotic types has a lot to do with counteracting a bacterial cell metamorphosis to be resistant to a type of antibiotic agent. So that's why we have such a large number of antibiotics that can be utilized. Another way that bacteria cells can be quantified, if you will, is whether or not they're gram positive or gram negative. Now, certain antibiotics are grouped according to their effectiveness based on a gram positive or a gram negative type bacteria. Now, the way the gram positive works, obviously a scientist called Hans Christian Gram came up with a method of differentiating two large different types of species, and it's got to do with the permeability or the defenses of their cellular wall itself. So a gram positive bacteria will actually soak up the dye because their wall is made of a substance mostly containing a peptide diglycan, is what their wall is actually surrounded by, and this gram stain will actually soak into that wall and therefore give it a purple appearance under a microscope, whereas the gram negative wall does not pick up the dye, so therefore it just stains the outside of it and it gives it a pink appearance instead. Now, another way of classifying bacteria in large groups is you may have also heard of an anaerobic or an aerobic bacteria. Now, that's basically got to do with whether or not they need oxygen in order to go through cellular respiration or cellular metabolism. And the way they test that is by putting the bacteria into a test tube and having the substance in the test tube robbed of oxygen. So if the bacteria is in fact aerobic, it will float to the top of the chest tube where it can get oxygen. If it's anaerobic, it'll be happily sitting within the medium of the test tube itself. Okay, that's enough on classification. Let's have a broad look at our ways in which antibacterial agents work. So in very simple terms, even though we're not the ones prescribing the antibiotics, it's a good way for us to know how they work in order to just have a better understanding on what sort of drugs we're given. So the different ways in which antibiotics work is either inhibiting or disrupting the cell wall or cell membrane itself. So it can either stop certain activities within the cell wall or cause the cell wall to break down. Another way is it inhibits protein synthesis. Okay, now protein synthesis, that's either making proteins through ribosome activity or actual DNA synthesis itself. And the last way is antibiotics that can interfere with some form of metabolic process. And we'll talk about each one of these classes of antibiotics, and we'll group all the antibiotics that we know into each one of these specific actions. So the first one that we'll look at is the most common one that you guys will be exposed to, okay, and that's antibiotic agents that attack the cell wall synthesis, okay, and they, as a large class, are called your Betalactams. Now, Betalactams are broken up into 4 main groups. There's only 3 written here, but the 2 most common groups that you will find is your penicillins and your cephalosporins. So within your penicillin groups, you'll have a lot of antibiotics that you'll know, and a lot of them are bioequivalents to one another. So you have your amoxicillin and ampicillin just by themselves, especially IV, they're quite bioequivalent. And then you also have your fluoroquinolines and dicloxacillin. They're also interchangeable, and they're used for things like MRSA infections or even normal staph skin infections. Now, when they're combined with some form of cavalitic acid or tanzobactam, then they're actually used for an extended sort of process that we'll talk about in the next slide. Now, your penicillins themselves are the most common one used. Okay, they are associated with a lot of allergic reactions associated with them, so they've got quite a high allergic reaction associated with them, but besides that, they're generally well tolerated and they're safe in pregnancy and breastfeeding. It can be used IV and orally as well. The second most common group is obviously your cephalosporin, so cefalexin, ceftriaxone, all those ones that are commonly known. They're also beta-lactams. Okay, but they're given for more of a wider spectrum against gram-negative bacteria. Okay, so your cephalosporins are very widespread and used for gram-negative bacteria. They're not penicillins themselves, but there is a similar makeup within their structures, which means there can be a cross-linkage with allergic reactions themselves. Now, the 2 other groups is your, obviously the one written, which is your carbapenems, and then you also have your monobactams as well. So they're 2 classes of antibiotics, and they still fit into the same overall class of beta-lactams, which are bactericidal, and they work on the cell wall itself. These monobactams and carbapenems, they're almost miscellaneous group of beta-lactams because they're not used frequently, and realistically you're not likely to see a lot of them apart from ertapenem, which is commonly used in trauma, some trauma centers when you're dealing with gastrointestinal trauma itself. So in relation to how they work, breaking down the synthesis within the cell wall, the gram-negatives, bacteria that we speak about, have a huge amount of osmotic pressure within them. Now, simply put, these antibiotics will come along and they will stop that cell wall from being able to fuse together. And if they can't fuse together, then the cell wall will break apart and the internal osmotic pressure will cause the cell to rupture. Okay, that's the main way that they work. Now, if the body builds up some form of resistance to this, meaning the simple beta-lactam comes along, blocks the receptor site to weaken the wall, and the bacteria counteracts that, basically pushes away the beta-lactam, then that's why we add the cavalitic acid or the tanzobactam, because that comes along and it takes away the ability for its resistance, so then the beta-lactam can break down the cell wall. Okay, so that's simply put. Like I said, if you want more detailed information, then go back to the other lesson itself. Okay, the next group of drugs that are associated with breaking down cell wall synthesis is your glycopeptides. Okay, the glycopeptides and your polypeptides. Now they're also bactericidal. Now vancomycin is probably the most popular one in this class. Now these work by inhibiting cell wall synthesis, but what they specifically do is they inhibit the peptide glycogen synthesis. So because of that, if you remember at the start, they're only effective against the gram-positive bacteria. Now, they can have a lot of toxic effects, which means their use is infrequent, and they're usually only reserved for the critically ill themselves. So there also can be a choice if someone's allergic to Betalactams itself and they want to get treatment for MRSA infections. Now there are certain diseases that are resistant to vancomycin, and that's obviously your VRE, so vancomycin resistant enterococci is that one. And there's a massive fear in the medical community if a MRSA bacteria somehow develops the same resistance that you'll find in VRE as well, because then what will happen is at this stage in our life, it will mean that we won't actually have any antibiotics to fight that particular bacteria. Okay, so that's the main risk or the main fear that's out there at the moment. Now, side effects associated with vancomycin, you can get severe hypertension and flushing of the upper body. So it's often colloquially called the red man syndrome. Now, it's more likely is if you give vancomycin at a rapid delivery, which is greater than 10 milligrams per minute. If you push that, then you're more likely to get these toxic effects. We'll move on to a different action of antibiotics, and we'll look at those antibiotics that work by inhibiting some form of protein synthesis. So the three classes that are associated with these ones is your Aminoglycosides, and they and all of these are bacterial static. So the main ones associated with the Aminoglycosides that we'll be used to is your gentamicin and your neomycin are your main class. Now a lot of them end in mycin, except for amikacin, which obviously ends in sin itself. Now this gets very annoying because your macrolides are also the same ones. Okay, they end in the same thing, so it makes it quite confusing to keep track of what antibiotic you're dealing with. But we'll go through it and hopefully help out with these. Now, when you're dealing with aminoglycosides, they're poor at oral absorption, and therefore they're given intravenously mostly. Okay, they're mostly given intravenously. They have a very narrow therapeutic range, very narrow. So it's important that if you're giving constant doses, usually after 3 doses for these ones, especially gentamicin IV, you want to start monitoring blood levels of the gentamicin. They are associated with quite severe adverse effects, including nephrotoxicity and ototoxicity, and these are permanent changes. So if you're giving aminoglycosides in a non-acute setting, then you should really encourage well hydration for the patient. You should also always administer these antibiotics separately, and if ideally separately by a number of hours from beta-lactam, okay, because they are physically incompatible. Now obviously if you're dealing with sepsis, a special sort of or highly acute illnesses, this the benefits outweigh the risk. Therefore, what I'm talking about here is when you have a choice. Someone's been put on a regime of these particular drugs through a 24-hour period, look at the regime and then look at separating them from there. Okay. If we move over to our tetracyclines, then we have 2 types. We have tetracycline, nice and easy, that's a short-acting one, and then we have doxycycline. So these all end in the cyclin side of the house. Okay, so it makes it nice and easy. They end in the cyclin, and they're a group of antibiotics that are used commonly because they're quite a safe drug to give. They're a very broad spectrum antibiotic, and they cover both gram-positive and gram-negative bacteria. Now, apart from doxycycline, this is a very important one for us to pay attention to, is, apart from doxycycline, these particular antibiotics should not be given with food, okay, especially food and acid, iron, calcium supplements, as they can greatly affect the absorption of especially tetracycline itself. Now, obviously, if you have adverse effects to doxycycline, it's recommended to have with food. Okay, now, also a very important note is it cannot be given to children, okay, because it causes the staining of their teeth permanently, and they also need to be avoided in pregnant women after 18 weeks of pregnancy because, again, you're going to discolour the baby's teeth on development. It also weakens them as well. It's not just the discoloration that we're worried about. And the last type is we've got our macrolides. So this is your azithromycin and erythromycin. So these ones, the way to tell the difference between a macrolide and an aminoglycoside, because they both end in mycin, is the macrolides will actually end in thromycin. Okay, so if you see any thromycin, then you'll know that it fits into the macrolide class. Now, these ones here are primarily metabolized by the liver and excreted in urine, so it's important that if a patient's on constant or high doses of these ones, you've got to be careful with liver and renal function, especially when you're dealing with the elderly. The other thing to note about the macrolides is they have a massive gastrointestinal effects, such as nausea, vomiting, diarrhea, up to a point between, depending on the drug, 5 to 30% of people taking it will actually have these effects. So as far as adverse effects go, they're very, very high. As far as their actions go, what they do, when we say that they inhibit protein synthesis, and we have nice little pictures here just to explain the difference. Like I said, full details of how this whole thing works, go back to the other presentation. So we'll start with aminoglycosides. Now what we're looking at here in front of you is the activity of protein synthesis happening in the actual ribosomes itself, in the involvement of base nucleotides bringing in amino acids. Okay, so that's what we're looking at. Again, if you're confused, there's plenty of other presentations to explain what's going on here. So looking at aminoglycosides, what happens with that particular drug is it comes along and it binds irreversibly to the 30S ribosome. Okay, so 30S subunit of the ribosome itself. So it will come along and it will bind to a specific point, specific nucleotides on the actual messenger RNA, and then it won't move. Because it won't move, it won't allow amino acid chains to form, therefore stopping protein synthesis. The tetracycline, which is the top one on the right, this reversibly binds to the 30S ribosome unit. Okay, so aminoglycosides irreversibly, and then tetracyclines reversibly. So what that does is it will actually block the same 3 base nucleotide, therefore stopping a specific amino acid from forming in a chain, and therefore inhibiting protein synthesis. And the last one, macrolide, similar to the tetracycline, as it binds reversibly to the ribosome, but this time it actually sits in between the RNA of the 50S subunits. Okay, so it actually blocks the binding of the peptide bonds between the amino acids. And then once it breaks that bond, it's free floating around to break another bond. So it doesn't allow the amino acids to form, therefore it stops protein synthesis. Okay, so that's how they all work. And they're all more effective on different types of bacterial agents depending on their penetration ability into the cell and how they bind with what is the most likely amino acid chain that bacteria is going to make. That's why we need so many different types for these particular ones, not to mention the overall bioavailability of our patients as well. Okay, moving on, we'll move on to the class of antibiotics that prevent DNA replication. Okay, so the main one in this particular group is called your fluoroquinolines. Okay, and these ones are bactericidals. So they're a class of antibiotics that absolutely inhibit DNA replication. So they stop the synthesis of all DNA. So fluoroquinolines, or quinolines as they're commonly known. So your ciprofloxacin is a classic example. They're basically agents that interfere with the ability for the bacteria to go through binary fusion. So if they can't replicate their DNA, then they can't replicate themselves. So it stops the actual multiplication. Now these particular drugs are very, very broad spectrum, and they can treat a huge variety of infections. They are used sparingly because they're associated with a huge risk of developing bacterial resistance. Okay? Because they're dealing with the actual DNA itself, there's a huge chance of DNA mutation, therefore resistance that will be found in the bacteria. So it's recommended that they're used sparingly, but they are very effective in a huge spectrum of disorders. Okay, so we're talking commonly used in complicated UTIs because of the penetrating ability to get into the bladder, same as bones and joint infections, and mycin, so any infection of the scrotum itself, and also prostatitis. So anywhere where it's difficult for the antibiotic to get to, these ones can be quite effective in those ones. Now they're commonly used in patients with cystic fibrosis as well. Quite careful when using these particular ones, but as I mentioned, they are very effective. Can have a lot of side effects. There can be things like tendinitis, arthritis, myalgia, and actual inflammation itself. So you're going to be, just like I said, they're a great antibiotic, but you just got to be that little bit careful with them. Now another type of drug that we all know and love that also interferes with DNA replication is your metronidazole. Now this is a completely different class of drugs. It's not a fluoroquinoline. It actually fits into the class of a nitromidazoles. Okay, so metronidazole realistically is its own class of antibiotics, and that disrupts DNA synthesis as well. Now the final action of antibiotics that we're going to look at are those ones that interfere with the metabolic process. So these are a class of drug. They're most likely your bacteriostatic, but your sulfonamides are a class of drug that will move into the bacterial cell and will actually inhibit the para-aminobenzoic acid. So what that means in simple terms, it actually stops the bacteria from synthesizing its own fluoric acid being produced. Now fluoric acid, as far as a bacterial cell is concerned, is needed for cellular maintenance. So if it stops that being produced, then it stops the bacteria maintaining itself, therefore it stops it being able to replicate because it doesn't have the required recipes. So your sulfonamides are often mixed with your trimethaprins as well to make them extra effective. Okay, and a classic one that we will know is your sulfamethasone trimethoprim, which is commonly known as your Bactrim itself. Okay, so your Bactrim is where this class of drug fits into. Now they're very, very effective against positive and negative, and they're really good for ear infections, UTIs again, and your general respiratory infections. Now the things to be careful of when you're dealing with these ones, you just need to know that again they're metabolized by the liver, excreted by the kidney, and it causes crystal urea. So crystal sediments can be found in the urea, and it can cause an irritation. So having a patient that is well hydrated is definitely recommended if they're on this class of drug for a long period of time. Other side effects with these particular ones, hypersensitivity, so angioedema, rashes and anaphylaxis are relatively common with this class. Now these are not your only classes and actions of antibiotics, however these are your main classes that you'll come across. Now you will definitely throughout your career find a lot of different ones out there, and when you do, just have a look into why they're different and the sort of things that they do. Right, now moving on, we'll look at the importance of laboratory testing. Okay, so when we're deciding to give antibiotics, now obviously every time I speak here I'm speaking of a non-acute based use of antibiotics, but before we decide to give antibiotics for an infection, it's always useful to get a specimen in order to isolate the causative organ. So then we can use a specific type of antibiotic that is most appropriate for that bacterial agent. So get a specimen depending on what is actually infected, so urine, feces, sputum, blood, any other fluid, nasal swabs, whatever it is, in order to test it. You can also test cerebral spinal fluid. You can use testing central lines, any PICC lines, catheter tips, doesn't matter what you test. You can even do biopsies. The point is, you get a test and then you conduct a laboratory testing to decide what bacteria it is. Now, certain testings that can be done is you obviously have blood cultures. So bacterial cultures that can come from blood or from specimens is the primary test used to diagnose a bacterial infection. Okay, result of a bacterial wound, usually available within 24 to 48 hours from the time the specimen gets to the laboratory. The result is specific for culture, for slow-growing organisms, such as your fungi and your macrobacteria. Unfortunately, if you want classes of those slow-growing ones, it can take several weeks. Your gram staining is a nice easy one that can be done, at least to give you in the ballpark of what type of antibiotics you can give in order to be most effective against them. But the most important one, or the most vital one, is your antimicrobial susceptibility sensitivity testing. That's where the pathogen is identified and separate in a separate test, and is used to determine what that bacteria is most susceptible to the certain class of drug. So they'll put it with a certain type of drug and they'll see what works best at stopping that bacteria from growing or killing that bacteria itself. Now, these test results can usually take about 24 hours to isolate that particular one, but technology is getting better. The use of laser scanning, things like that, is coming in order to identify bacteria a lot quicker. Now, the reason we want to do this is obviously to reduce the amount of over antibiotics that are used, okay? Because the biggest problem associated with antibiotics is, one, resistance, and then you've got your flow-on effect to allergic reaction as well. So you don't want to keep using broad-spectrum antibiotics when you don't have to. If you can give a tailored antibiotic for that particular specimen, then it is much better to do. Now, talking about resistance, the reason we have so many antibiotics out there is because of resistance. It often says that it's a big thing that people take the whole course of their antibiotics. So when you give an antibiotic, you want to take your own course, and that's basically to make it more effective and more likely to kill the entire infection. It often gets misconception with taking a whole course because it causes resistance. Okay, now there's actually not a lot of evidence out there that proves that if someone doesn't take an entire course of antibiotics, that they're actually going to cause that bug to be resistant. It's more got to do with taking the entire course of antibiotics in order to increase the likelihood of killing the pathogen, not allowing it to come back, lay dormant in your body, repopulate the area, that sort of thing. Okay, that's the main idea with it. Okay, but I know that it is definitely a common misconception associated with it. We're just going to finish up now, and we're going to have a look at what things that we should do for our particular patient before starting them on an antibacterial regime. So whether or not the patient has taken antibiotics before, always check if there's allergies. Have a look at what antibiotic has been prescribed and if there's any precautions or adverse effects associated with age or the reason your patient can't take it. Take a baseline set of obs, the reason why you want to give these antibiotics, so your temperature, respirate, heart rate, blood pressure, signs of infection, these will increase. And it also can be nice and handy to look into for the SIRS criteria to start moving into potential sepsis, which is a lesson on its own. If you're thinking there's an infectious state of a particular organ, then assess that organ. Okay, get a full assessment on that particular organ, and where possible, always collect a specimen for that antibacterial agent. Now, obviously, if you're in the field, you can't exactly get a specimen. That's why we have protocols associated with best course of antibiotics for a particular condition, and that works on probability a lot, I'm not going to lie. If you're dealing with the elderly or you're dealing with people with comorbidities, assess their liver and renal function, because a lot of antibiotics are put onto a regime based on their creatine clearance. Okay, so if someone has a reduction in their renal function, their creatine clearance is less, then they're more likely to have toxicity if they're given the same sort of regime antibiotics as a fully healthy adult. So when you're planning, look at the administration. Often drugs are given 3 times a day over a 24-hour period. So look at scheduling those antibiotics, talk with the doctors, and pick the best time for those ones to be given. If it needs to be avoided with food and drinks, like your tetracycline, then make sure it is. When people are taking the antibiotic for the first time, it's always best to observe them with the antibiotic, because it is a high-risk medication associated with anaphylaxis as well. So make sure they just keep an eye on them when you're giving it. Also, being a high-risk medication means that it needs to be double-checked as well. Any antibiotic that is given in hospitals is a double-checked drug. When we're implementing the antibiotic, okay, so we want to make sure that the antibacterial agent is given in equal intervals. Okay, so it's 3 times a day. You don't want to stack them all at the start and then don't give any throughout the whole night of 12 hours. You want to give it 3 times a day, the best equal interview that you can. If you're giving IV antibiotics, then you absolutely need to dilute it in accordance with the actual medication handbooks. Okay, there's rules associated with concentration dealing with antibiotics, which means you can't dilute them too far. When you're giving a series of antibiotics, you want to administer them alone. You don't want to mix them, definitely don't want to mix them in the same syringe, but you also don't want to push them straight after one another, especially if there's potential incompatibility that we spoke about. If a person is going away with antibiotics, okay, they need to give them the education on antibiotic resistance, sign of allergies, how to take care of the antibiotic at home, if it needs to be put in the fridge, kept away from children. If they decide not to take the entire course, encourage them to bring it back to the pharmacy for disposal. Okay, if you leave antibiotics in the house, a lot of people will get an infection and just take any type of antibiotics, and that's where the risk of resistance actually comes in. Talk to the patient about the potential for allergic reaction, even if they've had it a bunch of times, and then also make sure if people do have renal or hepatic problems, especially if they're given high doses of antibacterial therapies, monitor it with urinary output and ensure that they're adequately hydrated as well, especially if they're on things like gentamicin. After it's all said and done, you've given a regime of antibiotics, then have a look at them. See if there's still signs of infection. See if the antibiotic regime hasn't kicked in. As a general rule of thumb, your serum levels for oral antibiotics should kick in about 3 days. Serum levels for IV is straight away. So you should start seeing effects of IV antibiotics early, whether it's a reduction in temperature, heart rate, rest, the patient's well-being. They maybe get a little bit hungry again. Normal signs of infection. Any pulsy discharge, when they're on antibiotics that are bactericidal, there shouldn't be a lot of discharge. Bacterial static, yeah, you can still get discharge because obviously the body still has to get rid of what is there. Always look for potential signs, early signs of sepsis, which is a good one, is that SIRS criteria. If you're not sure what it is, just have a look. It's a nice easy one. Keep in the back of your mind for early signs of sepsis associated with organ failure. Okay, that is everything on pharmacology antibiotics. I hope you got something out of it. Until next time, take care.